If time is too late, so we can continue later tomorrow. Uh, as far as topic concern, I told you that my main purpose of the lectures were to give the concept to the student. So today my idea is to uh, revise the topic of anemia with the description and with the slides. So I think this is the time. I think you all free from the salat and from the palm or from your dinner. So be relaxed, see the slides and the description, but as well as you take the pen and a copy, because uh, in between I will ask the question, not to answer me at the moment. You just write down the questions and study the answers, and let me the answers when I will ask in the coming lectures, or maybe as a assignment, or maybe in the coming test. This is basically to give you, to make your subject and topic stronger. So this is not the one question, it will be many questions. So you all keep with you pen and paper, and I'll show the slide, the descriptions and the slides, and in between I'll give you the questions. You write down the questions. Don't need to answer me at the moment. And then read the books and find out the answers. And whenever I demand and I ask you to give me the answers, or I may take any test, so you have to give the answer at that time. This is basically beneficial and good for you people. So I think you all are ready. You have done the anemias. I may start the new topic. Polycythemia, I think today has been done. The platelets and the disorders has been done. So I can start the new topic. The lymphomas we can start. The leukemias can be started. But I think the anemia is the topic which should be more stronger, and time to time this is the topic you should have command on it. So I think uh, we will go slide by slide. Something I will describe, something I will give you the question in the slide, or is descriptive question. You write down these, and we will finish the topic. And by the end, collectively, you tell me how many questions, and then we will discuss what we have to do with these questions. Abdullah will be in the very end. You are coming. Okay. Okay, so should we start the slides, or someone waiting? Someone waiting for or finishing their namaz or lunch? Okay, right. So I think I should start the presentation. I go to the present, start the presentation. Okay, I'm starting now. you uh, presenting everyone. Okay, so come to the okay. So step of hemopoiesis. We already know a step of the hemopoiesis. What are the step of hemopoiesis? You know well where they occur in the fetus, yolk sac, liver, spleen, bone marrow. According to the age, 0 to 2 months in the yolk sac. Just recall 2 to 7 months in the liver and spleen, and up to the 9 months in the fetus in the bone marrow it is started. But in the infants it is in the bone marrow. In the adults, vertebrae, ribs, sternum, skull, sacrum, pelvis, proximal end of the femurs. These are the site of the hemopoiesis. This slide already you have seen, I shown you, and what is showing? It's showing the formation of the different cells, the red cells, platelets, monocytes, or all the white cells, the lymphocytes coming from the thymus, but the origin from the lymphoid stem cells and pluripotent cells. So how they originate from where they originate? So they originate from the mixed myeloid progenitor cells. So as we are studying the anemia, so red cells from the erythroid progenitor cells. And erythroid progenitor cells, from where it comes? Mixed myeloid progenitor cells. So at least this should remain in your mind. And most of the time we discussed and it remains in your mind, what is the role of the erythropoietin? Yes, erythropoietin is a stimulator. What it's do? It stimulates the bone marrow. And in the bone marrow, where it stimulates? It stimulates the and forms the pronormoblast. And pronormoblast forms the reticulocytes. So retic cells then mature and form the circulating red blood cells. But if there is rapidly coming into the circulation, so the retic cells they appear in the circulation. So basically, they are the oxygen sensors in the peritubular interstitium of the outer cortex of the kidney, and they stimulates the erythropoietin, and this cycles basically stimulates the bone marrow, and via this cycle, the erythropoietin plays its role in the formation of the mature RBCs. Got it? Okay. Then we come to the hemoglobin, and you know what is the hemoglobin, heme and the globin. So I'll not go in detail of it. The main function of the RBC is to carry the oxygen to the tissue and return the carbon dioxide from the tissue to the lungs. So for the function of the RBC contain a protein called the hemoglobin, heme and globin. So globin, each RBC, but for recalling, each RBC has 640 million hemoglobin molecules. That is to remember. Each has 640 million hemoglobin molecule. Too much required. Types of the hemoglobin, you know well, is the hemoglobin A. What is hemoglobin A? It has the 2 alpha and 2 beta globulin chains. Hemoglobin A2 has 2 alpha and 2 delta chains. Hemoglobin F has 2 alpha and 2 gamma chains. These are the types of hemoglobin. How it's synthesized, again, I'm not going in detail of it, but you see hemoglobin here. It forms 2 alpha and 2 beta globulin, and from the heme, the hemoglobin is formed. Right? So here is the iron, protoporphyrin, heme is formed, globin alpha 2 and beta 2 are coming and forms the hemoglobin. So this is the whole cycle and hemoglobin synthesis occur. And hemoglobin form in the RBC, which has the 120 days lifespan, as you know very well. And this RBC, why we are discussing, because there is a role of the shape and the expansibility of the RBC in the anemia. It is biconcave disc shape, able to generate ATP uh, through the EM and the pentose phosphate pathway. There is no oxygen pathway, but pentose phosphate pathway, as you know well. Got it? Now, it has a bilayer. RBC, red cell membrane. You see red cell membrane. Red cell membrane has a bilayer. You should have a basic knowledge about it. It's a bilayer and integral membrane proteins, which are very important because in the various type of its uh, anemia, we'll see the deformity takes place, and the integral membrane proteins are of various types. It forms the skeleton of the RBC. So there are the alpha and beta spectrin and ankyrin and protein 4 and 12 and actin are protein in the RBC membrane. So these are the very few basic structure of hemoglobin and the red cell membrane. So you know well now what is the anemia. Anemia is the reduction in the hemoglobin. Anemia is the reduction in the hemoglobin concentration of the blood. How much reduction? Below the lower limit of the normal range. And for the age and the sex of a person, because it vary for with the age and the gender as well. So also the lower limit of the normal range is reduced in the pregnancy as well. In the book, you will see the classification of the anemia according to the underlying mechanism. So you see the bold words, blood loss anemia, increased rate of destruction, hemolytic anemias, and then there causes the hemolytic anemias. Blood loss anemia, maybe the acute, maybe the trauma, chronic, maybe the lesion in the GIT, maybe the gynecological disturbances, hemolytic, maybe the intrinsic or intracorpuscular abnormalities, in the red cell membrane disorder, in the red cell enzyme deficiencies, in the disorder of the hemoglobin synthesis. It may be the acquired one. So all this you have to memorize and to see the book. What are the generalized symptoms and sign of the anemias? Already we discussed weakness, lethargy, palpitation, headache, low hemoglobin, the skin color. What are the lab findings? The red cell indices. We see the peripheral blood film. We see in the anemias to assess the type of the anemia and the severity of the anemia. Okay. So in different type of the anemia, the different picture of the morphology or the morphology of the cells present, variety of the picture, and the variety of the picture and variety of the shapes in one type of the anemia may be present. For example, we can say that in the microcytic hypochromic, microcytic hypochromic poikilocytosis, anisocytosis. Already you know these terms now. It means that they are smaller in size, they are lighter in colors due to the low hemoglobin, and there are variation in shape. They are not rounded even, they vary in shape. So they may be poikilocytosis. You see here in different types of the anemia, you may have the microsphere. Even they may be so fragile, they may be fragmented. There is a breakdown of the RBCs. They may elliptocytes, elliptical in shape. They are teardrop-like poikilocytes. They may basket cells. They may sickle cells. They may microcyte. They may have the acanthocyte. They may have the pencil cells, stomatocyte, target cells, macrocyte. These are the different as compared to the normal side. So in different types of the anemia, the peripheral blood film show, and there is a lot of the significance of the shape of the RBCs and the size of the RBCs. We call it the mean corpuscular volume, the mean corpuscular hemoglobin concentration, and uh, the shape of the RBCs as well. With the sickling, the poikilocytosis, the anisocytosis, everything. So already we have done in detail the iron deficiency anemia. What are the salient points of the iron deficiency anemia? The most common cause of the anemia in every country of the world is the iron deficiency anemia. And it is an important type of the anemia having the microcytic hypochromic anemia. Microcytic hypochromic. In the peripheral blood film, the smaller size RBC and low hemoglobin, the paler RBCs. The very interesting thing is that iron is the one of the most common element in the earth's surface, and yet iron deficiency is the most common cause of the anemia affecting the 500 million people worldwide. And there is a single reason, that body has limited ability to absorb the iron. So excess loss of the iron as a result of the hemoglobin is the iron deficiency anemia in its metabolism. This is the normal metabolism. You should have knowledge about it, and I think you have knowledge about it. But you see, in the there is a daily loss of 1 milligram. Average loss of the iron daily is the 1 milligram, and it's loss from the liver parenchyma right into the it goes in to the GIT from the via the circulation first into the macrophages. Destruction takes place. Utilization. So some of it goes via the kidney into the urine, stercobulogen into the stool. It passes, and some of again into the blood. It forms the pigments. Now, some iron is stored in reticuloendothelial system as a ferritin and hemosiderin. Ferritin is soluble, so it's not seen under the light microscope, but hemosiderin is insoluble, so seen under the microscope. So you can see some conditions in the hemosiderosis. If the hemosiderin is in excess, there are some condition, there are hemosiderosis. So in excess, so hemosiderosis, so you will see the deposition of the hemosiderin in the cells. Ferritin is soluble. Hemosiderin is insoluble. This you have to remember. As far as generally we discuss the symptoms of the anemia. So in iron deficiency anemia, in addition to the general symptoms, you will have the painless glossitis, inflammation of the tongue, angular stomatitis, inflammation of the oral cavity, colonychia, irritability, and decreased psychomotor development in children. These are the clinical features of iron deficiency anemia. Note down the question regarding the iron deficiency anemia, that due to the iron deficiency, how the glossitis, stomatitis, koilonychia, and psychomotor irritability and decreased psychomotor development takes place. These are given in many books. I know the underlying pathology, there's no time further. This is your homework. This is the first question. The clinical features specifically for the iron deficiency anemia, how these symptoms, what is the underlying pathology of these symptoms? This is the first question. I think you all write down this question. You wrote it? I think you have written it. And this is the picture. Brittle the spoon. You see the spoons, the nails of the patient. This is the ideal clinical picture of the long-standing iron deficiency anemia. Got it? This is the angular stomatitis. You see the angle of the mouth. So how it takes place? Causes already we discussed, that the chronic blood loss, especially from the uterine cavity or from the GIT, infancy, adolescence, pregnancy, lactation, and menstruation, the All these causes we discussed. So there is a balanced diet required, and there's a tendency for the negative iron balance. So from 6 months, supplemented formula, mild and iron fortified food prevents the iron deficiency, anemia, and pregnancy if not given. So the iron deficiency anemia may takes place in the pregnant women. So red cell indices or the labs shows what serum iron low. Obviously, this is the blood film showing iron deficiency anemia. TIBC increased. Obviously, total iron binding capacity. When there is low iron, obviously the binding capacity will increase. So total iron binding capacity increase. Serum transferrin receptors increase. Serum ferritin low. This is the picture you have. If you want, when you understand, you have to memorize regarding the uh, for the clinics of the as far as the iron deficiency concerned. Okay, and this is the ideal picture, peripheral blood film picture of the iron deficiency anemia. You see, you see the small round microcytic cells and empty cells, the paler area showing the hypochromasia or hypochromic cells, the microcytic cells, and the large number of the microcytic cells with some the, the cells showing the change in shape, and inflammatory cells are also there. Uh, and this is the ideal picture of the microcytic hypochromic iron deficiency. This is again with the high magnification and picture showing the hyper segmentation. But you see here, we can go in detail of this uh, lab investigation, but you just see the hemoglobin, and hemoglobin showing 9.7. So low hemoglobin. You just come to the mean corpuscular volume, MCV. And many times I've told you that we see microcytic anemia when we assess them into the femtoliter microcytic anemia when it is less than 90 femtoliter. Mean corpuscular hemoglobin should be more than 45, it's 22. So this is the ideal picture of the iron deficiency anemia. There are so many things which is related with the iron deficiency anemia, but at this level, at this stage, as a fourth year student, these are the 3-4 things. Mean corpuscular hemoglobin concentration is very low, 32. So at this stage, 3-4 things which basically reflects that it is the iron deficiency anemia. Okay. So hypochromic microcytic anemia, low serum iron and ferritin, total iron binding capacity raised, and the causes which we discussed, menorrhagia and the repeated pregnancies in female, male and female male blood loss, occult blood test should be performed, upper GI or the GI endoscopy should be done, and cause should be treated by the ferrous sulfate, or it should be correct anemia by the replenish the stores. So rarely parenteral iron should be given, Jactive or whatever. Now megaloblastic anemia or the macrocytic anemia or the other macrocytic anemia. So it means megaloblastic anemia doesn't mean only it is caused by the vitamin B12. There are so many causes of the macrocytic anemia. So let's see, macrocytic anemia, mean corpuscular volume more than 95 femtoliter. It's divided into the megaloblastic and non-megaloblastic. Why? Based on the development of the erythroblast in the bone marrow. It is a group of the anemias in which the erythroblasts in the bone marrow show a characteristic abnormality. What happens basically? Maturation of the nucleus being delayed relative to that of the cytoplasm. As compared to the cytoplasm, the nucleus does not mature. What happens? The nucleus chromatin maintains and open stippled. So it's lucky appearance despite the normal hemoglobin formation. Right? So basically, what is the underlying defect in the megaloblastic? The defect is the defective DNA synthesis, which results in asynchronous maturation of the nucleus. And usually it is caused by the deficiency of the vitamin B12 or the folate deficiency. Less commonly cause of metabolism or other lesion in the DNA synthesis. These are basically what? Vitamin B12 deficiency, right? Vitamin B12 deficiency causes what? It's where it occurs. Vitamin B12 deficiency is showing, and the folate deficiency. This is the comparison of the vitamin B12 deficiency and the folate deficiency. So actually the pictures shows the same symptoms. What I want to show here, just you see, I'm not going in detail of the biochemistry of it, but you see here in the slide, there is in the slide you see what? There is a DNA maturation. And DNA maturation from the beginning you see is by the dietary folates. So whatever the reason in the folate deficiency, by any mean, when the folate deficiency takes place, again the DNA maturation does not take place. The smart guys, students, they memorize the whole mechanisms. It's all up to you. Already you have done in the biochemistry and physiology as well. So it's just for the I think you're recalling if you have done this. So if dietary folates deficiency takes place, what will happen? There will be the DNA immaturation, and it may be due to vitamin B12 deficiency leads to what? From where we need due to the nutritional deficiencies, it may be due to the malabsorption deficiency. How the malabsorption? In cases of the gastric causes. One we have discussed in detail, like the pernicious anemia, but it may also be due to the congenital lacking of the intrinsic factor. It may be due to the partial gastrectomy. It may be due to the intestinal causes like the duodenal diverticulosis. आपने GIT तो पढ़ लिया है डिटेल में. It may be due to the Crohn's disease. It may be due to the tropical sprue. So whatever the cause, there are so many causes of the vitamin B12 deficiency. This we have done in detail. It may be caused by the autoimmune attack of the gastric mucosa leading to the atrophy of the stomach. There is achlorohydria and secretion of, if it's absent, almost absent, it is more female than the males are affected, and common in the Europeans. It occurs in the Europeans. So 90%.
तो काफी स्टूडेंट्स वेट कर रहे हैं, उनकी काइंडली आप रिक्वेस्ट एक्सेप्ट कर लें कि 8-10 स्टूडेंट्स हैं
किसके लिए
लेक्चर ज्वाइन करने के लिए, क्योंकि लैपटॉप की उनकी बैटरीज कम है. मुझे मैसेजेस आ रहे हैं काफी स्टूडेंट्स के कि आपको
you know from the beginning के 10 minutes, 15 minutes, half an hour is the time. मेरी क्लास में भी ये आदत है कि आई डोंट अलाउ आफ्टर 15-20 मिनट्स से। मुझे भी नहीं, अभी भी नहीं पता कि जिन्होंने बिगनिंग में ज्वाइन किया उसके बाद वो जाके अपने बेडरूम में लेट गए या वो खाना खा रहे हैं, बट एटलीस्ट व्हेन द लेक्चर स्टार्टेड, सो 15-20 मिनट्स इज क्वाइट एनफ कि उसमें ज्वाइन कर लें। उसके बाद भी अगर आप आधा आधा घंटा इसमें भी अगर इफ यू हैव टू कम आफ्टर हाफ एन आवर, तो मेरा ख्याल है कि उसमें सिर्फ अटेंडेंस के लिए आना कोई इशू नहीं है, उसमें ज्वाइन करना कोई इशू नहीं है। तो बिकॉज देयर इज ए इंटरप्शन, मुझे यहाँ से रोक के फिर वापस जाना, उनको फिर ज्वाइन करवाना, बट ओके मैं भी उसको यहाँ पे उसको रोकता हूँ मैं, बिकॉज आई एम ऑन द एंड्रॉयड, और मुझे खुद भी फिर यहाँ से ये इंटरप्शन उसको करना पड़ेगा कि ये रोक के पहले उनको ज्वाइन करूँ या उनको ज्वाइन करवाऊँ। ठीक है, तो नेक्स्ट टाइम के लिए ये है कि अगर आपने यस दे, ठीक है, यू ऑल थ्री पीपल remember in my lectures you know 15-20 minutes are quite enough। मैं इनिशियल जैसे लेक्चर स्टार्ट हो 15-20 मिनट्स में जिन्होंने ज्वाइन करना हो वो आप उसको कर लें। बेशक उसके बाद आप मोबाइल को रखकर आप अपना खाना वाना खाएं या बिस्तर पे आराम करें, लेकिन उसको काइंडली आप उसको जो है एक्सेप्ट कर लें, क्योंकि वो फिर यहाँ से उसको स्विच करना पड़ता है एंड उसमें फिर वो डिस्टर्बेंस होती है। ठीक है, तो what we are saying, there the other the so the parietal cell antibodies either may damage. There is a folate deficiency that may lead to damage. So what clinically takes place? Clinically, what happens in the megaloblastic anemia? Its onset occur gradually. Progressive symptoms takes place. The signs of anemia we discuss, it takes place, but it also leads to, because it gradually takes place, so slowly there is a destruction of the RBCs as well. So there is a jaundice as well. In case of the megaloblastic anemia, there is a glossitis, a beefy red sore tongue is the sign. There is an angular stomatitis. There are the symptoms of the malabsorption as well. There is a weight loss as well. There is a neuropathy, subacute combined degeneration takes place. And there is a peripheral sensory nerve and posterior and lateral column degeneration takes place. So the tingling sensation in the feet, difficulty in the walking also takes place in these patients. So these are the symptoms. Additionally, in the vitamin B12 deficiency takes place. But above all, when it takes place in a mother having a fetus, so folate deficiency and B12 deficiency in the mother predisposed to neural tube defect in the fetus. ऐसी मदर जिनमें वाइट फॉलिक डेफिशिएंसी हो, फॉलिक एसिड डेफिशिएंसी हो, उनमें चांसेस होते हैं कि बच्चे में न्यूरल ट्यूब डिफेक्ट हो जाएगा. So there is supplementation of the diet with the folic acid at the time of conception and in the early pregnancy is needed to reduce the incidence of neural tube defect. So 75% केसेस में ये ठीक हो जाता है. लैब्स क्या कहती हैं कि भाई MCV कितना होता है, मोर देन 95 फेमटोलीटर. नो, नॉर्मल कितना कितना यूजुअली कितना मिलता है, 120-140 फेमटोलीटर. मैक्रोसाइट्स किस शेप में होते हैं, ओवल शेप में होते हैं. ऑब्वियसली बोन मैरो में से रिएक्शन आता है, नॉट ओनली द रेड सेल्स, व्हाइट सेल्स का भी रिएक्शन आता है, प्लेटलेट का भी रिएक्शन आता है. सो देयर इज अ रेटिक काउंट low, the WBCs and the platelet count low. Or what is the reaction of the neutrophils? There will be the hyper-segmented neutrophils present in the peripheral blood. Uh, the hypercellular bone marrow reaction. The bone marrow show, bone marrow की अगर biopsy की जाए तो hypercellular bone marrow. And the red cells किस तरह show करते हैं bone marrow में? Erythroblast. There is an increased number of the erythroblast. क्योंकि प्रॉपरली सेल जो है वो आरबीसीज वो पेरिफेरल ब्लड फिल्म में अपीयर नहीं करती. दिस इज द शोइंग द लार्ज आरबीसीज विद हाइपर segmented neutrophils, right? Peripheral blood film in the megaloblastic end. This is a peripheral blood. Okay. And the other macrocytic anemias, कौन सी conditions हैं? You memorize it. Alcoholism में, liver diseases में, myxedema, myelodysplastic syndrome, cytotoxic drugs, aplastic anemias, pregnancy, smoking, reticulocytosis. All these conditions are the other conditions which leads to the macrocytic anemias. Got it? Okay, now come to the hemolytic anemias. Normally, after spanning life 120 days, red cell die. The physiological destruction of the RBCs takes place within the mononuclear phagocytic cells of the spleen. But hemolysis occur in the extravascular and intravascular system. Normal cells destruction hemolysis, the physiological destruction takes place within the mononuclear cells. Extravascular, intravascular किस तरह से? ये यहाँ पर you see this. Extravascular macrophage. Within the macrophage, RBCs are engulfed. Destruction takes place. Globin, it transforms into the amino acids. Amino acid release हो गया. Iron, it binds to the transferrin. Protoporphyrin turns into the bilirubin. Bilirubin is unconjugated bilirubin. It goes to the liver. From the liver, bilirubin, it goes to the glucuronides. Go to the gut. So stercobilinogen. So it gives color to the feces. Or some of them reabsorb and into the kidney via the circulation, then filter out, so give color to the urine, urobilinogen. So this is basically the utilization of it. You see, basically the RBCs, lyses, hemoglobin, okay? Then to the kidney, hemoglobinuria directly, and hemosideruria. This is the intravascular system. So it happens, but causes of the intravascular. So what will be the causes of, you should know the causes of intravascular or extravascular hemolysis. You see here written the mismatched blood transfusion. These are on your tips. Causes of the intravascular hemolysis: 1, 2, 3, 4, 5, 6. Mismatched blood transfusion, G6PD deficiency, red cell fragmentation syndrome,